This lecture is on the pathology, etiology and management of navicular stress fractures. Any patient that presents with dorsal midfoot pain that is exercise induced, it's important to consider the possibility of a navicular stress fracture. However, the majority of navicular stress fractures will probably be seen by those working in a sports medicine environment, unless the practice that you're in has a sports focus. It's a particularly important pathology to pick up because it is considered a high risk fracture. Therefore, management needs to be quite aggressive to reduce the load on the navicular. There are a couple of useful references to help guide you through this lecture. I would encourage you to have a look at the chapter on foot pain by Bruckner and Kahn. Bruckner and Kahn's Clinical Sports Medicine, I think it's from page 844 in the 4th edition. There's a nice section on navicular stress fractures. I'd also suggest that you have a look at the systematic review and meta-analysis by Torg and et al., which provides the highest level of evidence for the effectiveness of various interventions for navicular stress fractures. Navicular stress fractures are primarily seen in track and field athletes, sprinters, jumpers, hurdlers, though you will also see them in the middle distance athletes as well. And it's been found that 59% of navicular stress fractures are accounted for by track and field athletes. And it's also been found that it's the second most common foot stress fracture, with an incidence around 14 to 35%. Just remembering that the most common stress fracture in the foot is of the second metatarsal. When evaluating a patient that you suspect has a navicular stress fracture, it's particularly important that you look at their history or their training history leading up to the development of their symptoms. More often than not, they're going to have a history of overuse. They've either increased the type, the level, the frequency of the activity leading up to the development of their symptoms. Typically, the patient will describe somatic type pain, so a deep, dull, poorly localized ache overlying the dorsolateral aspect of the midfoot. So don't be surprised if the patient is pointing not only to the dorsum of the foot, but down towards the dorsolateral aspect of the midfoot. Quite often the patient will feel that their shoelaces are done up too tight, and as a result they try and release the tension of the lace to give them relief. Pain generally increases with weight bearing, so the more the patient loads the midfoot and loads the navicular, the more pain they tend to experience if there is a fracture. And nocturnal symptoms are particularly common, so when the patient goes to bed, if they have a navicular stress fracture, they'll get intense somatic type pain overlying the dorsum of the midfoot. It's particularly important that you ask the patient about the presence of nocturnal symptoms and how the pain is behaving, because they won't tell you otherwise. The symptoms the patient describes will clearly alert you to the possibility of a navicular stress fracture, but you need to ask the right questions. There is no real high-level evidence for risk factors for navicular stress fractures. However, a number of factors have been associated with the presence of navicular stress fractures, including a rigid midfoot or mid-tarsal joint. So you will note that the majority of people that present to you with a navicular stress fracture will have a rigid midfoot. So there'll be very little dorsiflexion, plantarflexion, abduction, adduction, inversion, eversion of the midfoot during gaits. They tend to have a neutral to slightly cavus foot type. You might also note that the patient has an ankle equinus. So if there is reduced ankle joint dorsiflexion, then that range of motion might be compensated by movement at the more distal joints that can provide dorsiflexion, so the talar navicular joint. And if the talar navicular joint is attempting to compensate for a lack of ankle joint dorsiflexion, but it cannot do it because it's rigid, then more stress might be applied to the navicular. It's also been proposed that bending forces through that region might also predispose to a navicular stress fracture, but also the presence of an avascular central portion. So The arteries that supply the navicular supply the medial and lateral sections, and there's a small avascular center. So therefore, it's believed that it increases the risk of certainly delayed healing if a fracture appears at that site. The biggest risk factor, or the biggest factor associated with navicular stress fractures, are training errors. So the people that have a stress fracture will always have a history of overuse. They've either increased the type, the level, and or volume of activity leading up to the onset of their symptoms. It's also possible that reduced bone density in a particular patient might increase the risk of a navicular stress fracture. So it might be relevant looking into their history of osteopenia or osteoporosis. The symptoms that the patient describes will certainly alert you to the possibility of a navicular stress fracture. However, you will still need to undertake your active and passive range of motion testing, as well as your muscle testing, to rule out the possibility of joint and or muscle involvement. But in regards to palpation, it's important that you palpate the end spot, which is the dorsal aspect of the navicular, roughly in the central third of the navicular, between extensor hallucis longus and tibialis anterior. So it's applying a force in the plantar direction on the dorsal aspect of the navicular between the two tendons, and this test has an 81% sensitivity to detecting a fracture, and the patient will be particularly tender when palpating the end spot if they have a navicular fracture. Quite often when palpating the navicular tuberosity or the medial aspect of the navicular, quite often they are asymptomatic, so it's important to find that dorsal central aspect between the two tendons to reproduce their symptoms. Also get your patient to hop, jump, skip, dance in your room to help elicit their symptoms, and a patient with a navicular stress fracture will be able to reproduce their symptoms with hopping and jumping and skipping in your room. This is the diagnostic and treatment algorithm, just to help guide you through the process of making an appropriate diagnosis, which will then help you make and develop an appropriate treatment program for your patient. So in the case of a navicular stress fracture, it's considered a high risk fracture, mainly because it's prone to delayed healing, mainly because of that avascular central portion. So it's not too dissimilar to the base of the second metatarsal or to a Jones fracture. It requires a little bit more aggressive treatment. So imaging is quite often used to help with your clinical diagnosis. Some people will start off with an X-ray to determine if a fracture is present, and if it is positive, then the patient will go straight generally into a 6-week program of strict non-weight bearing cast immobilization. However, only about 17% of navicular stress fractures will appear on X-ray. Therefore, many practitioners, particularly the sports physicians, will start with a bone scan. If the bone scan is negative, then it suggests that there is no fracture, nor is there a stress reaction. In that case, there might be joint involvement or there might be muscular involvement, maybe an issue with tib post or tib ant or extensor hallucis longus. If the bone scan is positive, however, it suggests that there is increased uptake of the radioisotope at the level or within the bone, but that doesn't tell us what the problem is. Is it an infection? Is it a tumor? Is it a fracture? Is it a degenerative change within the adjacent joint? So if there is a positive bone scan, then quite often the physician will refer the patient for a CT scan. Now, if the CT scan is negative, it might suggest that there is simply a stress reaction and the patient might need 2 to 3 weeks of weight-bearing rest. However, if the CT is positive for a crack or a fracture within the navicular, then once again the patient would generally require a 6-week period of strict non-weight-bearing cast immobilization. These two figures highlight the two most common imaging techniques used to help diagnose a navicular stress fracture. On the left we have a bone scan, and you'll note by the position of the arrow that there is increased uptake or a hotspot of radioisotope at the level of the navicular. But once again, it's a very sensitive test, but it's not very specific. It doesn't tell us whether this patient has a tumour, an infection, or a fracture within the bone. But then you'll generally just need to rely on your patient's history and the signs and symptoms that they have described to you to help come up with that diagnosis. But more often than not, if the patient's had a bone scan and there is increased uptake of the radioisotope, the physician or the GP, whoever has referred the patient for the scan, will also request a CT. And on the right, you will note on the far right image a crack within the dorsal aspect of the navicular, extending into that avascular central portion of the navicular. In regards to the conservative management of navicular stress fractures, if a patient has a stress reaction, it's generally recommended that they have a 2 to 4 week period of weight-bearing rest and then a gradual return to exercise. If they have a fracture of the navicular, it's generally recommended that a 6-week period of non-weight-bearing rest is required in a below-knee cast, although there is some conjecture as to whether this is the most appropriate course of action. However, Karim Khan in 1992 published a study that found that 86% of participants with a navicular stress fracture healed with this sort of regime. Some physicians suggest that if the end spot is still tender when the cast is removed, then they will put the patient back into a cast for a further 2 weeks. Some physicians in the past have also used imaging after that 6 to 8 week period of rest to determine the presence of a fracture or increased uptake of the radioisotope, and if there is still evidence of a fracture or increased uptake, then the cast is placed back on the foot. However, there is some conjecture as to whether this is appropriate, and some physicians just rely on clinical indicators and palpation to make a decision. In the event that the patient has been in a non-weight-bearing cast for a 6-week period, they will have lost some strength and power and muscular endurance within the musculature of the affected limb. Therefore, they will need a strengthening program to get them back to pre-injury strength. They might have also lost some range of movement, particularly the ankle, subtalar, mid-tarsal, so some mobilization of those joints may be required. Some massage therapy might also be of benefit to improve the length of the musculature of the affected limb, which will in turn improve range of movement at the ankle, subtalar and mid-tarsal. It's particularly important that your patient returns to exercise very, very gradually, because the navicular is prone to re-injury, mainly due to that avascular central portion. In regards to prevention, it's important that you address the intrinsic and extrinsic risk factors that the patient presented with that might have been associated with their symptoms. Generally, it's going to be issues relating to the type, the level and volume of activity that they've been undertaking. So you may need to write a program for them, certainly to get them back to activity, but write a program for them that will help them prevent further injuries to the navicular.